Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri.
And I'm Andrew Sanchez.
And we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
All right, I guess chit chat for the week. I don't have too much to say, to be honest. I'm on teaching service. I got one or two good cases maybe in the pipeline for the podcast. Definitely one from admitting last week. I think it's going to be the next case I present to you, actually. But otherwise, the weather's been really nice here. More runs. What have you been up to?
Are you rollerblading?
Not yet. I'm itching to now. The thing is, so now everyone's using. So we practice in the basketball court, but now since the weather's nice, everyone's using the basketball court. So I need to wait for people to kind of relax a little bit, so I'm not out there just embarrassing myself in front of people.
Not ready for I-95 yet?
No, not yet.
I got myself addicted to a video game called Civilization. It's pretty common. I feel like a lot of people have heard of it, but I waded into the deep end and I'm fully enthralled. So hoping that game ends. It's a 500 turn strategy game. So I'm at turn 460.
Oh my god!
I'm looking forward to not being addicted to the game after I finish. So.
Wow, I don't know anything about that game. I guess our listeners can email Mike any of their Civ tips, and we'll see how that goes.
Please do. I have no idea I have no idea what my end game is here.
I love it. All right. So speaking apart from civilization, the case today, I have 4 aliquots. The pacing for you is going to be kind of important. It's really more 3 aliquots, and aliquot number 4 is giving a big slash of data, basically leading up to a diagnosis that's honestly kind of up for interpretation. It'll kind of be me giving my thoughts and then you giving your thoughts, and then we'll see what the listeners have to say. So really it's just 3 aliquots though. First one is going to be super short. Second one is going to be kind of some HPI data and then some imaging from taken in the emergency departments. And then aliquot number 3 will be like you actually going and examining the guy yourself and getting your own history. So aliquot number 1, it's a guy in his 40s and he's presenting with a painful red leg on the right side. And I'll just stop there.
Oh my. The classic emergency room presentation. So I've heard that it's unilateral, right? Okay. So that's probably the first branch point here. I guess I'll just give you my general idea of how to approach red legs as they walk into the emergency department. So I think there's many different ways to break this problem down, and sort of dichotomous ways I think are helpful. So there's sort of 4, and I'll do my best to keep it brief, although that's not my strong suit for those who have already listened many times. So there's unilateral versus bilateral. There's acute versus chronic, right? Local versus systemic, which really means that this is sort of isolated to the leg versus you've got this thing on the leg, but you've got either a rash somewhere else or just other things going on somewhere else, right? And then I think the last one is going to be, in this one, it may, especially since you're telling me it's on this podcast, so I imagine it's going to be something a little bit more esoteric, and so I find it also helpful to know what happens to the leg when I raise it, because how it responds to gravity is going to tell us a lot about, hopefully, the underlying pathology. So I'll just go through each of those quickly. Unilateral versus bilateral is probably the most important, and probably the thing that if you take nothing else away from any talk that you have on red legs, that's probably the first ones, right? So unilateral is much more likely to be isolated to the leg itself, right? So you have infection like cellulitis or dermatitis, another an irritant, not necessarily infection. DVT, right? Something that is isolated to below the pelvis on that side of the leg. Whereas bilateral processes are generally going to be related to something that's happening systemically, or at least in both of the legs, right? So very unlikely that you're going to have infection on both sides, right? Bilateral cellulitis is, definitely it's a no-no word on the IM wards, right? So, and that's just because it's very unlikely that you're going to create an infection of the similar severity, tempo, and acuity at the exact same time on both legs looking the same, right? So, that's going to be much more likely to be things like chronic venous stasis dermatitis, right? A late complication of that. Just lower extremity edema that can look red just because of vasodilation and congestion, nephrotic syndrome, CHF, cirrhosis, malnutrition, and protein wasting. And I think those are sort of so that's the first thing I think. And then the next, of course, is going to be acute versus chronic, right? So again, acute presentations are, especially unilaterally, are going to be very likely to be something that's, again, isolated to the leg, infection, dermatitis, DVT, and then complications or variations of those things. And then something bilateral that's acute, you're thinking like a rash, basically, right? So do you have some sort of like vasculitis? Do you have an acute heart failure exacerbation that maybe is causing some erythema? And you can have like an acute venous stasis, but it's a little bit more rare. It's a thing for sure. The one caveat for bilateral acute infection, quote, would be something like a superimposed fungal infection, but usually that's on top of something that's more chronic, right? So you can have that, but we're not talking about Staph aureus and strep, right? We're talking about other things. Local versus systemic, right? So if you have something on the lower leg, even unilaterally, but then you also have fevers, chills, a white count, now you're making the argument that this is an infectious process, or at least an inflammatory process. Whereas if you have no systemic symptoms, then it still can be cellulitis, right? But maybe we're not dealing with cellulitis and sepsis. Whether or not you have a DVT only, or whether you have a DVT and then a PE, right? If you have someone with this finding and then they're also short of breath, that changes, right? Things that you're thinking about. And then I think the thing that will be helpful also for listeners is when you elevate the leg, what happens to the finding, right? So we're really talking here about erythema, red leg. We're not talking about any of the other things that I'm sure we'll find out on HPI here. But basically, the reason that you get erythema is for a few reasons. But I think trying to bunch it into two big categories, mostly because we're going to raise the leg, and I want to say that there's two things that can happen. So first, if you have something infectious or inflammatory, then you're going to get leaky capillaries, right? Leaky vessels. That's just what happens. It's why we get edema with infection anywhere. And if you have leaking vessels, right, and you elevate the leg, maybe in a day or two, you'll see some improvement, right? Because you just have less return to the leg from the arterial side. But right away, you're not going to see much improvement at all. It's going to stay erythematous for the most part. Again, I'm really making it very dichotomous here, but for the sake of the argument. If the problem is not leaky vessels, but rather dilated vessels, so the vessels there's nothing wrong with their permeability. It's just the fact that there's a lot of either pressure in the vessels or the vessels have dilated for some reason. That should get better when you elevate, because as you increase gravity's pull on the blood there, then you're going to just drain the blood out of those big, fat, dilated vessels, right? So think about it as, do you have a sieve or you just have a big bag, right? If you have a sieve and you raise a sieve up, the sieve's still going to leak, right? But if you have a bag and it's down below you and then you raise the bag up, bag means vasodilation, right? Big chunky vessels. They're big like a bag. The bag then drains, right? That's like how we give people IV fluids. So that's like another way to think about it. I'm going to stop there. Let's hear what other qualifiers or clarifiers there are from there. I guess I should just mention quickly, sorry, that
No,
like what is
always more
going to
Mike.
cause what is going to cause a vasodilated vessel, right? Easy to just say random pathophysiology, but let's attach it to some conditions. So first, I mean, you're going to get if you have a lot of back pressure on the vessels from things like heart failure, then you're probably going to get, vasodilation. If we raise legs that are edematous from heart failure, they tend to improve, right? DVT, very similarly, it's just more proximal, right, to the issue rather than something way up in the right atrium and the IVC, right? So that's going to be the most common. And then the other thing is going to be conditions that I'm going to do a very poor job of describing. Really, just one that I know of, which is that it's called complex regional pain syndrome. Basically, the way I think about it, and this is probably wrong at best, hand waving, but you get some sort of trauma and you get crossing with that trauma or surgery, crossing of sympathetic nerves on top of sensory nerves. For lack of a better word, basically, you get pain, the pain system and the autonomic system get crossed and mismatched. And now you get pain, but you also get vasodilation because the autonomics are sort of all just, the wires are crossed. I'm sure that there is a vascular surgeon or probably anyone else who's willing to correct me on that, and I welcome it. But that's the way I think about it, and it's helped me so far. And then the last thing would be not so much vasodilation because of back pressure or because the vessels are pathologically dilated, but actually it's an appropriate response to poor inflow, right? So if you just have a really poor inflow, it's peripheral arterial disease, ischemia, then you're going to have a vasodilated state. And on the other side, right, to try to compensate, and the arterioles will also dilate. And then when you raise the leg, right, you drain the bag. So there we go. That's the framework.
Amazing. 4 frames. And I think our episode logo is going to have to be a sieve or a sieve, however you say it. Yeah, I'll give you some more info, and we're definitely going to come back and we'll see what frame you choose. And I'll give you some answers that'll help you kind of use one or two of those approaches. So before giving the HPI, I'm actually going to start with some background history, which you'll see why this is important in a sec. So this is a patient who's actually, and again, he's in his 40s. He's actually been having issues with his right foot and ankle for many, many years because it was actually run over by a car when he was only 5 years old. So based on how you describe the complications occurring immediately after that accident, it sounds like he had an open wound that required a flap reconstruction. But ever since that very remote accident operation, he hasn't had any recent surgeries. And in his adulthood, what he's been left with is a quite deformed joint. X-rays taken at a podiatry visit a few months prior to when I meet him show, quote, chronic deformity of the tibio-talar joint with anterior subluxation of the foot, chronically deformed distal tibia, fibula, and talus, severe soft tissue swelling in the ankle, and diffuse osteopenia. And picture's worth 1,000 words, so let me send you the photos, which are going to go up on the website if I can get this to work. Okay, so this is him standing at the podiatrist office. No like acute symptoms at that visit. This is kind of like his chronic joints again a couple of months before. I'll just let you kind of like just take a gander for a second, then I'll keep going.
And so the first photo here, again, this will be on the website, everyone. The first photo here is his sort of at chronic baseline, and the second photo is him showing up acutely for you.
Oh, I'm sorry. Both of those are chronic. Yeah,
both are chronic.
Yeah, but these are just like different angles is all. Yeah.
Gotcha. Okay.
Yeah. Okay.
Thank you.
Yeah. So now that you've seen the joint, I'll let you know that he's actually been ambulating without assistance for the vast majority of his life. He only recently started to use a cane as he's been having more falls due to worsening stability of the joint. He says he's had chronic intermittent pain flares of the ankle and foot for many years, and he's only used menthol-based creams from Mexico to alleviate the symptoms. So for his past medical history, otherwise, he only has HIV, well controlled on antiretroviral therapy. 4 beers are consumed per day. There's been no sexual activity in the last year and no IV drug use. So why is he being admitted to you today? He says that beginning about 2 weeks ago, he began to notice increasing pain, swelling, and redness of the ankle and foot. From his perspective, he thinks he's been walking a bit differently due to the worsening joint instability issue I mentioned. And he thinks maybe there was like some more friction against the medial aspects of the joint where his skin is kind of thin. He then decided to go to his PCP because he could no longer bear weight without excruciating pain. He has no systemic symptoms. They acquired an x-ray that showed mild edema surrounding the ankle. And again, this was actually already seen on prior imaging, and a small amount of radiolucency underlying the area of thin skin. He then is sent to the ED. A CBC is drawn, shows a white count of 8.3, normal. A normal cell differential, it's only 58% neutrophils. A CRP is sent and 33 mg per liter. And no fevers are demonstrated in the first 48 hours. And I'm going to show you a photo of what the ED took on this acute presentation. And then I'm going to ask you 2 questions, of course.
Okay. So for the listeners, and again, I encourage you to go to the website and take a look yourself. But so at his chronic baseline, he has pretty marked, I would say, swelling, although I don't know that that's actually edema, of the, basically, it looks like medial worse than lateral ankle joint. He has this really significant scar, I think it is, like basically a keloid on the anteromedial surface there at baseline again. And it almost actually, it almost looks like there should be some stitches there, but there isn't. It's a chronic, basically just a chronic keloid scar where I imagine they did some sort of operation or something. The new photo now actually doesn't really show much change to that medial swelling of the joint, but the joint itself, or excuse me, the keloid scar now is, markedly erythematous. I can actually see some drainage. So it looks like maybe there's an ulcer or something, some break in the skin there. And yeah, it's just, it's much darker, more erythematous, and there's this maybe ulcer, something is leaking out, which looks to be at least serosanguinous, if not just some blood, actual blood. But it's not dripping down the side of the ankle. It doesn't seem like there's like a pressure to this.
And just because it'll be helpful to you, Mike, I'll let you know that like podiatry saw the patient in the ED, and they said there's some like serous drainage, but no purulence.
Perfect. Yeah, that's what it looks like from the picture.
Awesome. So, you've seen this photo taken in the ED. You have that available to you when you go to meet this guy. Like walking into the room of this patient when you go to meet him, are you like feeling pretty confident with the diagnosis? After you let me know what you think is going on, I can let you know kind of what my own exam was when I went to meet him, and I can give you answers to kind of any other questions you have about his symptoms. Because of course, this is part of what I gave you is part of the history I took, but I kind of like hid some information just to kind of be more authentic to the case.
Yeah. Just one clarifying question. So I think you had mentioned no fevers, no tachycardia, no other systemic symptoms that would suggest inflammation or infection.
Yeah, absolutely right. Mm-hmm.
Okay, perfect. So I think that the first question that you're always going to be asked when someone certainly has unilateral erythema is going to be, right, is this infectious or not? And so I think actually I'd say that I don't have a slam dunk diagnosis. I'll be willing to say, because I don't think that this is necessarily obviously cellulitis. It's erythematous, but it actually really sort of, it respects the borders pretty. It does. It's not sort of tracking up or down, up the ankle, up the shin, or down the midfoot much. And it's not very edematous either, outside of just the chronic kind of keloid. And he did say it is painful, right? And he thinks there's increased swelling, and that's fair. There may be, right? I'm just looking at a picture here, but I'm not seeing something markedly so. He's not showing us any signs of systemic infection, right? He doesn't have a white count. CRP was normal. Doesn't have fevers, tachycardia. And this is on a chronic issue, right? He has a chronic problem here, dermatologically and in the joint. So I think if I'm asked to sort of say that I'm confident this is cellulitis, I'd say no. And I think, it's always helpful to have ways to think about cellulitis in general. So there's something called the ALT 70 score, which, it's just a score, right? He certainly would not have been included in the studies because he has an existing joint arthropathy, chronic as well as a keloid, right? So, but for what it's worth, it really uses asymmetry, age greater than 70, leukocytosis, or a heart rate greater than 90, tachycardia, basically, the way I'd think about it. And you get 3 points for asymmetry, 2 points for age greater than 70, and then a point each for white count and heart rate. And so he would score 3. Actually, what this thing would recommend is it has basically 3 options. It's essentially, don't worry about this, it's not cellulitis, consult dermatology and or infectious disease, or treat. Those are kind of the way it risk stratifies. And so just plugging him into this formula, it would say consult infectious disease or dermatology would be the recommendation from this single score, right? That probably does not include patients like him. So I think that's the score sort of tracks on to my own uncertainty. I think the thing I would be more worried about would actually be something deep to the keloid, right? Would be like, does he have some sort of septic arthritis there? But also doesn't sound like that because he should be much sicker. But again, I think we'll hear an exam here. But I'm going to stop there. And I think you had some questions for me as well.
Yeah. I think no, that's perfect. Perfect stopping point. We could just keep the case moving forward. Very interesting about the score. I never heard of that before. Our listeners are going to love that. So you go and meet this guy, and here's what he says. As the image suggests, he has significant pain over the medial foot where there's substantial erythema, and there is edema. It's kind of hard to tell. You can't palpate through a photo, but he does have some edema there. And again, the x-rays in the past have shown kind of like chronic edema from his arthropathy. However, he says he also has pain circumferentially around the leg, about 15% up, and pain over the entire foot. He says he's had pain in this distribution before, but it's never been this severe. Otherwise, he says he has chronic intermittent numbness in the back of the ankle and foot that he says is positional. Other than the focal erythema over the medial ankle, you don't see such profound sort of like cellulitic like changes over the foot or the leg. And it's really at these non-angry appearing areas where the pain is still very much out of proportion to your genital palpation. So he really has like pain out of proportion to genital palpation, not just over this like anteromedial kind of keloid that you keep commenting on, but also up the leg a little bit and around the entire foot. So based off of your bucket number 4 of a red leg approach, you raise the leg and you look very closely at the dorsal surface of the foot, and you see that there is subtle redness or flushing of the skin that quickly resolves when you elevate the foot from supine to 45 degrees. Let me show it to you just so I can put you in my shoes here.
Very audiovisual. I like.
Yeah. This is our most. These are gonna be the most images, I think.
Okay, so Andrew has a video here for me that I'm watching,
and I really feel like it's on the descent where you can kind of see the change more so than the ascent.
Yeah. Okay. All right. Yeah, I'm a believer.
Okay. Glad to hear that. I asked my resident and the medical student like 3 times, are you guys seeing that, or am I making this up? And I have with the power dynamics, they maybe feel compelled to agree with me as the attending. They said that they also feel like they saw it too. So at this point, the repeat CBC in differential at 48 hours, still normal. And it's really here that there's a crossroads in the management plan. So I'll just stop here and ask not only where your head is at now, but kind of what your final moves would be, with the options spanning like withhold antibiotics and observe, give antibiotics and observe, give antibiotics and work up further, or literally like anything else. This is kind of like the beauty of management reasoning. And you'll see in a second in real life, my plan was different than the plan of the attending that came on. And we'll see what you would do at this point.
So I think I would withhold antibiotics and work up while we have him here. So thinking about, this is just on the right side. So thinking about, let's go back right to our framework. We we have something that's acute, but acute on chronic, and there actually is even some chronicity to some of the things he's mentioning, right? Not all of this is new. He's, what he said, he's had pain like this before, and so just on the right side, he right. So DVT, I think I'd probably just rule that out. The foot, now that I'm actually seeing it from the angle of the video, there's a fair amount of edema to the lower half of the midfoot and the toes. I'm taking a look at his, imaging, or sorry, his pictures from baseline. He definitely has some there, but it seems more pronounced. So I think it's reasonable to just do the unilateral edema workup and get a DVT ultrasound. That seems cost effective. The pain out of proportion is always something that requires pause, and right, because you're worried about deeper infections, things like neck fash, abscess, compartment syndrome. I think I'd be more worried about something like that if there was a traumatic injury that preceded this. But correct me if I'm wrong, Andrew, but I don't hear that there was a trauma immediately preceding this. This just kind of happened, but not with respect to something.
Yeah.
Okay, perfect. So, I don't know if I would go further. You could consider doing a CT of the ankle and the midfoot, and if that didn't show anything, then go for MRI if you're really so concerned. But again, no white count and no tachycardia and no fevers, and just be honest, the video doesn't look like something that's deeper, right? There's no like duskiness to it. There's no purpura. You're actually seeing erythema that then goes away with, there seems like there's good flow right in. So then I think what I'm actually kind of left with is, one, how does this respond to just nothing? Like if we don't do anything in 12 hours, what is this going to look like? Which sometimes we don't like that plan in the hospital, right? But just give them a little bit of time and see what happens to this as you're working things up. The reason is because I think we had mentioned it, right? That things like complex regional pain syndrome, he definitely has risk factors for it, right? He had trauma to this before. He actually sounds like he has maybe even some of that syndrome at baseline, right? He has got some neuropathic findings, kind of comes and goes. And so I wonder if this is a flare of complex regional pain syndrome, which, will get better if we treat it with, actually menthol is not a bad option, right? Like topical, in fact, the fact that it responded to that tells you something, right? The topical neuropathic treatment and elevation and some time as well. And then the other thing would be, and you'll have to just give me a little rope here because I could be hallucinating this, but I believe that you can get with chronic joint deformity, Charcot, I think is what we would call it. You can get similar findings to complex regional pain syndrome. I actually kind of in my head think about them as the same thing because the risk factors are sort of similar, but I'm sure that they're discrete entities. But it could be that. And then so in that case, it's like a flare of a chronic problem, I think is if I was thinking of what this really likely is. I also think that like, what's his function, right? Like, is this going to now mean that he has to use a cane or a walker, right? Are we not going to be able to discharge him from this perspective? And what does the patient want too, right? Like, is the patient okay with getting some imaging, seeing how things go for a night of, topical treatment, and getting sort of a PT evaluation? Or does this a person who like says, I really feel very uncomfortable with that plan. I want more certainty. And in that case, I probably would just talk to infectious disease if I'm being very transparent. Maybe dermatology, maybe infectious disease. Maybe I'd put them in a group chat and say, who wants to see this first? But, right, because I think that I don't feel comfortable treating it with an antibiotics, and I don't think I would do that by myself. But if a infectious disease doctor or a dermatologist feels that this looks like something they would treat, then sure, I'm certainly happy to. I think the other big thing though, right, is you got to make sure he doesn't have septic arthritis because this thing does cross a joint that we know has arthropathy, right? So it's higher risk for septic. But again, that's going to be I mean, I don't see anything that we can tap, and he's not showing us any signs that would suggest an infection of that severity. So that's my approach. I'd love to hear what others think. It's very nuanced here.
Yeah, a couple comments. Jumping to the nuance, this is a super nuanced, complex case. I'm about to just give you a dumpster load of information. So sorry, listeners, you got to listen to my voice for like 10 minutes now. But that's this case. Two, amazing discussion. And I know Zahir listens to this podcast, and he was like, you guys don't know the answers to these when you're doing it. And commenting on some of your discussions, Mike. You'll see why I'm saying that in a second, because I had the exact same thoughts as as you had, and I'm shocked I didn't tell you about this case beforehand. And three, I just love the way you're approaching the path forward. We actually also really looped in the patient for kind of what was the come, because there were so many different divergent paths forward. And the initial plan actually was he was okay with leaving, and part of the decision making was basically this guy's joint is so messed up. At the end of the day, podiatry was like very eager to basically amputate him just because it would make his life a lot easier, but he was like not at all there. So kind of knowing that was the ultimate plan, he was kind of like okay, like going home, but then he changed his mind, and you'll see in a sec kind of what came of that. So okay, let me get back on track. So how did he do with the initial antibiotics? So he had very mild amount of improvement in the ankle pain after 24 hours of vancomycin given in the ED, followed by de-escalation to Keflex when we took on the patient, because we were kind of much more I was much more reassured when I took on the patient, just like you. So I'm going to give my initial impression from my attestation. Quote, the lack of systemic symptoms, inflammatory marker elevation, distribution of pain being way beyond the site of cellulitis, deep weight-bearing pain, and pain out of proportion to exam beyond the site of cellulitis altogether are not consistent with simple skin and soft tissue infection. And in fact, the vast majority of the patient's symptoms and exam findings can be accounted for by a much more compatible diagnosis, complex regional pain syndrome. The clinical diagnosis of CRPS hinges on meeting 3 of 4 Budapest criteria. So we got to hit on 2 criteria this episode. This includes sensory symptoms like allodynia, vasomotor symptoms like skin color changes, pseudomotor changes like edema and sweat changes, and motor trophic changes like decreased range of motion or strength. Now, I shared this case with some orthopedic friends because this is super complicated. I needed their thoughts. And they actually corrected my attestation to reflect high suspicion for the sister syndrome you mentioned, the acute Charcot joint. I'll explain the mistake I made at that juncture in a second. And I need to take a step back and for the audience explain what CRPS and acute Charcot joints really represent, so we're all on the same page. So these are 2 sister syndromes of pain out of proportion to exam that are frequently mistaken for infection, given the severity of pain, and also the local inflammatory features of both the skin and, importantly, the bone. So syndrome number 1 is Charcot foot. In patients with polyneuropathy, this is often how we think of them, or focal neuropathy, like in a patient who had a prior crushed foot and their pediatric history, neuropathy results in a dysregulated local inflammatory cascade that causes significant inflammation in the soft tissues, i.e. it's a cellulitis mimicker. Also the bones, i.e. it's an osteomyelitis mimicker, and the joints, so it's a septic arthritis mimicker. And after unchecked inflammation, the bones become literally eroded and the joints become unstable over time. Syndrome number 2 is the CRPS, complex regional pain. This is also a syndrome of neurogenic inflammation, but instead of being related to underlying neuropathy, it's triggered by some form of trauma, as you mentioned, in 90% of patients, and actually nothing in 10% of patients. So both syndromes are tied together by these dysregulated neurons you walked us through, leading to arteriolar vasodilation. Both easily recognized when you observe the rapid resolution of erythema when you raise the affected limb. And this is because you already taught this. You lose the gravity-mediated blood pooling in those dilated arterioles. So taken together, I felt the best kind of term. I was like, we need a name for both of these because, as you said, like they're related. What do we call them? This is not in the literature. Borrows from how people talk about Charcot. I call them both neurogenic osteoarthropathies because they share this pathophysiology, and they both lead to image positive bone findings that basically mimic osteo, going back to our osteomyelitis mimickers schema. And really, Charcot is a much stronger mimicker than CRPS. CRPS can do it, but Charcot is much more impressive in the bone than CRPS. So my mistake in the initial attestation note of calling the CRPS was, oh, this guy, like, he doesn't have diabetes, he doesn't have like a toxin exposure, he doesn't have neuropathy, he doesn't have Charcot, but it's CRPS. And then my orthopedics friends were like, no, his foot was crushed, his nerves are totally destroyed from that prior injury, and he tells you he has an intermittent numb foot, so he has neuropathy just in that foot. Also, by the way, Zahir just texted me in the middle of this recording saying, I'm loving these last new episodes. Thanks, Zahir. So with that in mind, when I was leaving service, my ideal management plan was to observe on antibiotics treating for non-purulent cellulitis with strict no weight bearing to assess for improvement of basically a Charcot joint. The plan did not happen when I left service, as a new attending had other thoughts. MRI was done, showed moderate sized tibio-talar joint effusion with thickening and peripheral synovial enhancement, mild edema, and enhancement of the distal tibia and fibula, and enhancement in the subtalar joint. Despite the patient having some clinical improvement, orthopedics and podiatry ultimately didn't feel comfortable with the possibility these changes were non-infectious in origin. So he was brought to the OR where the joint was washed and then flapped to cover that area of kind of like keloid and delicate skin, with a long-term plan for a joint fixation rather than amputation. 3 cultures were sent, 2 from the synovium and synovial fluid, and 1 from bone. All 3 grew a sparse amount of Staph epi, Staph lugdunensis, and Finagoldia magna. Sadly, bone pathology was not sent. He was discharged on a 6-week course of linezolid. So before I tell you how he's doing, so I do have a 1-month follow-up after all of that went down, some quick notes on the bone culture. I ran this case by Brandon Lee to debrief on some of the nuances on interpretation of the bone cultures. Brandon basically said that in a messed up joint like this guy's, you can certainly see growth reflective of chronic osteo. So bone culture growth in this guy doesn't necessarily equal acute osteo. That said, he said the bone biopsy procedure theoretically increases the risk that you see that chronic bacteria even deeper. So these folks who could have had chronic osteo, typically not requiring antibiotics, often do get antibiotics just because of caution. So with that in mind, this guy's synovium membrane culture still agree the same organism. So how do we interpret that? How does this change things? Our reflex, tells us to treat this as acute septic arthritis. Like, how do we get around that, right? But then again, in talking to my favorite local ID fellow at BI, Noah Rosenberg, we should keep in mind that Staph epi and Finagoldia these are like really indolent organisms, and chronic osteo kind of is in line with this this growth, and this can lead to sinus tracts that may even communicate with the synovium. So basically, could this all just be chronic osteo? That said, how is he doing now? It's the most important question. So he's been getting linezolid for like a month after discharge. He was just seen in the ID clinic. CBC and differential checks, both still normal. CRP is still elevated, but lower at 6. He is still having, quote, significant right lower extremity pain. That's how it says, significant. So going back to when I left service, being authentic, I was kind of annoyed when my original managed plan wasn't followed, but knowing now that the patient is still having this, quote, significant pain on antibiotics, I think we would have ended up having to do all of this workup anyway. So I'm very glad that it happened, because we have everything we would want to know. But it does leave us a question basically of interpretation at this point. So the final aliquot, Mike, what do you think happened?
Man, yeah, that's a very nuanced case, and it gets harder once you have culture data. So first, I think the 2 things can be true at the same time. I think you can have both of these things, and so that's just an important thing to keep in mind. I don't think it has to be one. People are not on the boards, right? People have many different things, especially in someone who has a joint that has this many different risk factors for so many different conditions. I think that the idea of chronic osteo is fair, right? I think oftentimes the problem with people who have chronic venous stasis or chronic joint deformity is that they are at higher risk of getting disease, right? Infectious disease than the person who doesn't have any either joint or skin pathology. So, I mean, it's a real thing, right? And the fact about trying sinus tracts, that point is taken because, I mean, you could definitely see from the picture how that's possible. I mean, it's where that serous sanguineous drainage is coming out. Is that continuous with the effusion and the synovium? I don't know. It's possible. That's a good thought. The issue I think I have is that it didn't seem like it got better with the antibiotics. Linazolids should work. I mean, I guess there's not great penetrance, I'm sure, to that space, particularly with all the damage there. But you'd think after 6 weeks on linazolid, you'd have some improvement if that really was the driving pathology, right? An infection of the synovium should be very painful and should get better with antibiotics. So definitely could have had a chronic infection or acute on and chronic infection. And then you could also have complex regional pain syndrome. I think my final thought is it could be both. I think what I would do is I would stop antibiotics and I would treat for complex regional pain, or I guess Charcot, and then see, right? Like, we can bring people back. He's 45 years old. I imagine he's going to be able to come back into the clinic in a couple weeks and he'll tell us if he gets worse, right? He presented to the emergency department. So, I think that's reasonable, right? And if the pain gets a lot worse off antibiotics, or, God forbid, he shows us any signs of systemic symptoms, then for sure that was the problem, right? And at that point, he probably does need amputation, because I just don't know that there's going to be another option for treating this kind of chronic infection if it didn't respond to 6 weeks of linazolid. And if the pain either didn't get any better or did get a little bit better, then that suggests it's maybe not infectious. So I don't think I added a whole lot of clarity to the question you asked me, but I think if I had to make a final decision, I'd say this is a guy who has either CRPS and or Charcot, and then maybe also developed a chronic osteo.
Yeah, I had to look this up. Chronic infectious synovitis, which is typically like these weird like mycobacterial like things, but in this guy is a bit different because he has like probably chronic osteo. But I landed in the same place, Mike. I think we'll never be able to say with 100% certainty. I think when we think about our pre-test probabilities, kind of where we're at with these tests, I was framing this as very like low pretest probability for infection. So the finding of culture growth in a guy who could have chronic osteo, I was thinking at best this only gets me at like an intermediate probability space. This is truly like an acute infection. There are just a lot of pitfalls in the interpretation of the data here. And we're of course obligated to treat this guy. And I, as importantly, like you said, that was something that I didn't take seriously enough when I was kind of at that crossroads point. Was he could have two things. Like, I was framing as this was all acute Charcot. He probably had like cellulitis and Charcot at the same time. And regarding this idea of was the joint acutely infected, I don't know if we can say with certainty. I think it's possible, but I think the chronic hypothesis is also strong. And this is diagnostic atypia. It's probably one of the weirdest but most fun cases I've ever had. I'll say it'll be on my mind for a very long time for sure. And I hope he's walking again, like soon, maybe in like a month or two. But I agree. I think that him not being able to like walk on, it's still based off of the ID clinic note. Probably this is something non-infectious, and his joint is just so destroyed and so bad. People will be able to see it on the website and make that determination for themselves. But thank you, Mike. I got nothing else.
I have one question. Does it mention in that note if the erythema has gone down since they've done this, since they've treated with antibiotics?
I didn't take note. No. Mm-mm.
Okay. Yeah. Not sure it would really help a whole lot, but if the visual appearance got better on antibiotics, I guess that would also suggest, right, that there was a cellulitic component to this. But again, cellulitis shouldn't get better if we elevate it, not that fast. So, but it sounds like it's probably two things. And I think the one thing I learned many things, but the one thing I wrote down here is just that there's no trigger in 10% of patients with complex regional pain syndrome. I just thought it had to be either surgery or trauma. So that's interesting. If someone doesn't have those things, I just rule it out. So that's a mistake on my part, and that's a learning point.
Hey, well, I hope we have some CRPS and Charcot experts in the audience somewhere. Please email us. Let us know what you think. I reached out to, as you can tell, many people to get their inputs, and definitely let us know what you think about this case. Take it easy and have a good week.
Thanks everyone for listening. Take care. This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.